Treatment of juvenile inflammatory arthritis. When you have more than two joints involvement and for more than 6 weeks in a 16 years old child and less than 16 years old child, you have diagnosis of JRA, juvenile inflammatory arthritis, and you have this. It is the diagnosis of exclusion. These varieties are oligoarticular when you have less than 4 joint involvement, and polyarticular means more than 5 joint involvements, and enthesitis related arthritis ERA when you have tendon sort of insertion sort of involvement. Systemic features when you have features of the whole body, liver, spleen, fever, rash, etc. And you have sometimes how you treat the oligoarticular JRA. Drug of choice in oligoarticular is the NSAID. Commonly used drug over here is naproxen, at times indomethacin, and intraarticular triamcinolone injection at 3 monthly, maybe 3 shots in a year. If no response with this NSAID and the intraarticular triamcinolone, what we give oral prednisolone and disease modifying agent DMRD. They are methotrexate, leflunomide, and sulfasalazine commonly used throughout the globe, and go on giving it. So the polyarticular JRA, when more than 5 joints are involved, the drug over here again is the NSAID, but the next drug may be your DMRD like MTX, methotrexate. When there is no response by 1 month, you give oral prednisolone 0.2 to 0.5 milligram per kg, bit less than the standard. No response, we give hydrochloroquine, and no response yet, we give the leflunomide. And then your see for 6 months no response, then you give your biologicals like etanercept, infliximab, tocilizumab, abatacept, and rituximab, commonly available in this country, and anakinra. So these are the 6 or 7 the biological that can be used at the end of the non-response. And enthesitis related arthritis, you have again NSAID, indomethacin is not bad over here, sulfasalazine, yes, second drug, and third drug no response, you have DMRD, and finally the name, as I said earlier, methotrexate, leflunomide, and sulfasalazine, and no response, you give the biological agents, rituximab, most common one available throughout the globe, in this country also. So in systemic JRA, you give the IV methylprednisolone 3 doses, 20 to 20 milligram per kg, and followed by oral prednisolone and your subcutaneous methotrexate. No response, give NSAID. No response, you give DMRD and biological agents. So do not give steroid in the beginning. So what is the rule of steroid in your JRA? So it is a bridge therapy. It is a flare therapy. Flare therapy is a little bit higher, 0.5 to 1 milligram per kg. When the disease flares, obviously the term means switch therapy. When you're switching from one group to the other medications, it's a little bit more, 1 milligram per kg per day. And we use intravenous methylprednisolone in severe cases. As I said, the IV methyl in your systemic onset disease, and followed by oral disease, and your intraarticular and intraocular steroid is also used when there is significant eye involvement. So duration of therapy is decided by your patient response. So usually it is you go on giving it for 6 months. When disease is inactive, called DI, the inactive disease, and C for the CRM, complete clinical remission. So see for another 1 year or so, patient is doing well for another 1 year. So you quit or taper MTX, and then then you have then you have the discontinue, and finally you discontinue. Up to lowest dose of MTX may be 10 milligram, and then you discontinue. Then you see patient is well for another 1 year or so. Then you call it complete clinical remission. Then you perhaps quit or taper and wait. If the disease returns, you go for the restart of the therapy.